Hello again, and welcome to our University of Alberta Child and Adolescent Psychiatry live grand rounds. So I'm Dr. Alice Liang, the moderator for today, and also our other moderator, Dr. Daniel Moreno de Luca. And Dr. Moreno de Luca is a child and adolescent and adult psychiatrist who is also our CASA research chair and the principal investigator and director of the PRISMA research group. We remain pleased and grateful to be partnered with the Faculty of Medicine and Dentistry, Office of Lifelong Learning, or L3, and the Physician Learning Program, or PLP, for these rounds. So a couple reminders. One, we have our sign-up sheet in the back. So for our live audience, if you haven't signed in yet, if you can make your way to the back at some point to sign, that would be great. And also the reminder that our grand rounds will be changing the time and date as of September of this fall. So our rounds are going to be occurring on the second Thursday of the month from 8:30 to 9:30 rather than the current time. And so our next grand rounds will be on September 11, starting at 8:30 a.m. And for this session, in addition to us sending out our session evaluation, please be on the lookout for the annual evaluation for our rounds. Okay, let's see if we can do our, land acknowledgement. So our territorial acknowledgement, the University of Alberta, its buildings, labs, and research stations are primarily located on the territory of the Nehiya, Cree, the Nisipatipi, Blackfoot, Métis, Nakota Stoney, Dene, Haudenosaunee, Iroquois, and Ninishabi Ojibwe Saulteaux lands that are now known as part of Treaty 6, 7, and 8 and homeland of the Métis. The University of Alberta respects the sovereignty, lands, histories, languages, knowledge systems, and cultures of all First Nations, Métis, and Inuit nations. There might be some housekeeping. I think we have a combination of live questions and chat. So definitely, if you have a question, add to the Q&A. And for those who are in our remote audience, and if you have questions about technical issues, please use the chat. And we'll be doing a combination of both live and virtual questions today. So now I guess I'll turn it over to Dr. Moreno de Luca to welcome our esteemed speaker.
Thank you, Alice. Just step over here. Hello and welcome to today's special edition of the University of Alberta Child and Adolescent Psychiatry Grand Rounds. I'm Daniel Moreno de Luca, and in my role as the CASA Research Chair and on behalf of our team, I am delighted to host the and CASA Research Chair Child and this brings outstanding clinician scientists to our community, offering the opportunity to learn from their work and, just as importantly, to foster meaningful collaborative relationships across our teams. By in-person interactions. None of this would have been possible without the tremendous support from CASA, the University of Alberta, Alberta Health Services, and the team, especially the one role in coordinating today's visit, and our colleagues at the Faculty of Medicine and Dentistry's Office of Lifelong Learning, better known as L3. Now, it's my great pleasure to introduce today's speaker. Dr. Matthew Siegel is a nationally and internationally recognized child psychiatrist, healthcare leader, and researcher dedicated to improving care for children with autism and developmental conditions. Mental health at Boston Children's Hospital, where he leads an integrated behavioral health continuum across both Boston Children's and its affiliate, Franciscan Children's Hospital. In this role, he plays a central part in shaping clinical strategy and innovation in pediatric mental health within the academic framework of the Harvard Medical School. He is also professor of psychiatry and pediatrics at Tufts University School of Medicine. Dr. Siegel earned his MD from Stanford University School of Medicine, his BA magna cum laude from Amherst College, and an MBA from Brandeis University Business School. He trained in the triple board residency program in pediatrics, psychiatry, and child psychiatry at Brown University. He is the founder and principal investigator of the Autism Inpatient Collaborative, a multi-site hospital-based research platform that has deeply characterized over 1,500 children with severe autism and developmental conditions. Funded continuously for more than a decade and supported by the Simons Foundation, the AIC's dataset is widely shared with investigators and has generated over 35 peer-reviewed publications, with Dr. Siegel authoring more than 20 and serving as the senior author on several of them. A special issue of the Journal of Autism and Developmental Disorders was dedicated to the Autism Inpatient Collaborative in 2018. Dr. Siegel's research focuses on emotion regulation and the treatment of complex, challenging behaviors in children with autism, especially those with profound autism. His early work helped build the evidence base for intensive treatment strategies, and he has led the development of clinical guidelines for psychotropic medication use in this population. He has also studied the effectiveness of specialized inpatient psychiatric units, developed and evaluated care pathways for general inpatient units, and published consensus treatment guidelines in the Journal of the American Academy of Child and Adolescent Psychiatry. In addition to his clinical and academic work, Dr. Siegel developed a multi-level continuum of behavioral healthcare for individuals with autism and intellectual developmental disorders, employing more than 200 staff and anchored in the creation of the 28,000 square foot Glickman Lauder Center of Excellence in Autism and Developmental Disorders, which opened in 2021. Dr. Siegel is not only an outstanding clinician scientist, but also an inspiration for us as a team and a close ally of our friends on the autism spectrum. Please join me in giving a warm welcome to Dr. Matthew Siegel.
There, yeah. No, I'm good. I need the slides. Okay. Great. Thank you. Okay, we're good. Thank you. Thank you, Dr. Leung. Thank you, Dr. DeLuca. It's great to be here. It's refreshing to be north of the border and in a different environment. I won't say any more about that because that could take the next year to talk about. But anyway, so I'm Matthew Siegel, really glad to be here. I'm a child psychiatrist and pediatrician, as Dr. DeLuca said, at Boston Children's Hospital now. Previously, I was at Maine Medical Center in Portland, Maine for 16 years, so I'll be talking about some of that. And so what I wanted to do today was share with you a pretty clinically focused talk on how we developed a multidisciplinary assessment and treatment service for youth with autism and intellectual disability, and embedded in it research and training for the next generation and provided service at multiple levels. So that's what I wanted to share with you because I think I understand, you have wonderful resources here and are continually thinking about how to form into kind of your next steps. So disclosures, employee, have research funding from various sources, and also have sort of served as a consultant to a number of systems and hospitals, none of which I think represents a conflict for what I'm talking about today. So we'll talk a little bit about this population and the behavioral challenges that we see sometimes from this population. Then we'll talk about psychiatric hospitalization, and particularly specialized psychiatric hospitalization for this population. And the point is both to talk about that type of care, but also use it as an example of a model of how one can do interdisciplinary or multidisciplinary care for the population, how you can blend things to try to address really challenging things. And then I'll tell you a little bit about the research collaborative that we formed of those units. So hopefully you'll emerge from this with a idea of the prevalence of challenging behavior in this population, some of the idea of some of the evidence for these specialized units, and can talk a little bit about what we think are effective elements of these programs. Why are we talking about this? Well, so youth with autism or ID, thanks. I don't know what you did, but thank you. Youth with autism or intellectual disability, there are many things we could talk about, but something that doesn't get talked about very much, although it was certainly something we talked about yesterday when I was meeting with some of your faculty, is the fact that kids with autism or ID and adolescents and adults end up in the emergency room with a fairly high frequency. And they end up there actually at a much higher frequency than kids who don't have autism in this study example. And they're ending up there frequently with mental health concerns, usually behavioral exacerbations, right? That's not something we talk about very much or have had a great deal of research about, but it is a fact. Another thing supporting the reason I say it's a fact is because we've had several studies around it. And one that I found striking was at the bottom here, there was a study in Massachusetts where they were looking at what we call in the US ED boarding. Boarding means you've gone to the emergency room, you need a psychiatric hospitalization, and you are waiting. You are waiting to get into one of those psychiatric beds in a psychiatric hospital unit, okay? So boarding is bad. We don't want to board. You're sitting in the ED, not getting care, usually unhappy, not good things are happening because the ED is not where you want to be. So why do people board? Why do kids board? Well, this study showed that the number one predictor of boarding, i.e. getting stuck in the emergency room, was having autism. The second highest or greatest predictor was having intellectual disability. So this is just supporting, this is a big issue for this population, is not only do they have exacerbations and end up in the emergency room, but then they get stuck there because it's difficult to move on to, if they need a further level of care, difficult for them to move on to it. So as I was saying, they end up in the emergency room with some frequency. And that is often due to what I would call serious challenging behavior, which means physical aggression or self-injurious behavior. And these things are unfortunately somewhat prevalent for the population. So a couple of things you will see lots of different figures around this depending on the sample that's looked at. So in a clinical sample, so the Autism Treatment Network, which is a series of specialty autism clinics that was supported by Autism Speaks, mostly in the US, the parents were asked, is your child demonstrating physical aggression, like right now? And over 50% said yes. That's a stunning number. Now, that's not a community sample, right? That was a clinically referred sample. So it should be higher, but that's still very high, I think. And then in a non-clinically referred sample, so a very broad sample, 8,000 kids in the US, looking at records, the question was, has there been self-injurious behavior? It was still a quarter of the kids with self-injurious behavior. So also a fairly prevalent issue. So those things land kids in the emergency room, and then often, although they get stuck on the way, land them in psychiatric hospital units, at least in the United States, and as I understand it, to some degree here in Canada. And so we wanted to understand, well, what are the risk factors for that happening? And there's been a number of publications on this, but one thing that we did is we looked at two cohorts. One, a cohort that we developed called the Autism Inpatient Collection that I'll tell you more about, and another cohort that's an outpatient cohort that was developed in Rhode Island that actually Dr. DeLuca was part of, called RICART. And what we found was your risk for psychiatric hospitalization was greater if the child with autism had lower adaptive functioning, had greater autism symptom severity, had a single primary caregiver as opposed to like a two-parent household, and the presence of a mood disorder or sleep problems, each independently raise the risk of psychiatric hospitalization. I wouldn't say that any of that is particularly surprising, but it was good to look at what are the risk factors that raise the risk. So why do kids get psychiatrically hospitalized when they have autism or ID, so a neurodevelopmental disability? And so when we looked at this a decade ago, the overwhelming answer was externalizing, or what I'm calling challenging behaviors, right? So aggression, SIB, which is self-injurious behavior, property destruction, and then a mix of other tantrums, decreased functioning, sexualized behavior, et cetera. So externalizing behaviors. So they're not primarily getting hospitalized because of depression, suicidality, or paralyzing anxiety. If they have those things, it's often being expressed as externalizing behaviors, okay? This becomes important in a minute. So let's step back for a second. So why, it may sound obvious, but why is that a problem? Why is it a problem that a kid is physically aggressive or self-injurious or destroys property? Like what's the problem? Well, there's the obvious immediate problem, which is it can be unsafe in the environment. Like that's obvious. I think what's less obvious, and kind of we've come to appreciate on my team over years and years of talking with families about this, is, and what they tell us is that these behaviors are actually, for them, these are the problem. They will say, they will say somewhat casually, I'm paraphrasing, we can handle the autism. We can handle the intellectual disability. We can deal with the 12 systems we have to work with or whatever. We can deal with it somewhat. What we can't deal with, and what greatly impacts our family, is we can't go to the grocery store because we don't know if he will become upset and attack someone or throw something, et cetera, he or she. And so there's been multiple studies actually where have shown this, and have shown that it's these behaviors that are of greater concern and impact for the family than the core autism symptoms themselves. And so I think that's pretty remarkable, and also something that I think people who work clinically recognize, but it's not talked about a great deal. It's not represented in our research literature frequently. And so, of course, this has all kinds of downstream effects. So if you can't go out to dinner as a family, you can't go to the grocery store, you can't go to summer camp, it then increases, of course, all these other things: family stress, isolation, financial, and other things. So another way to put it is another way that I like to think about it is the other problem with these behaviors is they can bend the developmental trajectory of the child downward. So what do I mean by that? So this is kind of a made-up graphic. So let's say development on the y-axis, age on the x. So child is getting older. This is child Y, and this is their ideal or potential developmental trajectory, right? This is what ideally is going to happen for them, this kid. So they're going along, this kid, let's say, has autism, moderate intellectual disability. They're going along, they're in, let's say, a therapeutic preschool. They're getting good treatment. They're learning how to communicate. They're learning how to learn. Terrific. And then they start to hit other kids in the preschool. So what happens? A therapeutic preschool, and I don't know what the equivalent is in Canada, so I'm just using US terms. So what happens? Well, they get kicked out, right? Because that school, even though it's a autism or ABA preschool or whatever, they can't handle that behavior when it starts hitting other kids. And so, or let's say it doesn't extinguish quickly. So they get kicked out of the preschool. So then suddenly they lose access to everything they need that's helping them progress on their developmental trajectory. Their communication system stops developing. They stop learning how to learn, they stop socializing. And so their developmental trajectory potentially starts to drop off. And it usually takes 6, 12, 18 months to get back into another program. So they're just at home, usually getting no intervention. And then let's say, this is made up, they're older, they get back into a program. Now they're 7 years old, they're in a public school, they're progressing, but it's overwhelming. And as an expression of their anxiety, they start engaging in self-injurious behavior. They start hitting themselves when they feel overwhelmed. And this starts happening frequently, tens, dozens of times a day. When kids hit themselves, that's highly distressing to everyone around them, as it should be. And they are asked to leave or not, they are somehow asked to not attend that school anymore, or they just end up being at home. And so I won't belabor the point. You get the point that these behaviors impact access to everything this child needs. It's really a terrible irony that what they need the most, they can't access because of these behaviors. And so it can, create a situation where their development is affected and they end up along the way, and they end up with a gap between whatever their potential was and where they are, right? And maybe the most extreme example of this would be, we were talking about a kid the other day that's been involved in a system here where has ended up at, 18 or 20 years old, who's like in the basement, no interaction, can't leave the house, and their story is not dissimilar from this made up story I just gave you. So another way of saying, what's the problem with aggression or self-injury? Well, it's way beyond the danger in the moment. That's a problem, but there's a lot of other problems, okay? So it needs treatment and attention, right? So the question is, if you're gonna assess and try to treat this, the question, like everything else that you're trying to assess or treat, is what is the etiology? What's causing this, okay? And what I would say is a way to think about this is that it's a final expression of other things, okay? So aggression and self-injury are kind of like a final common pathway symptoms, if you will. So the question is, what is it a symptom of? And the answer can be many different things. I'm going to give you a bunch of things that we think about, not in a particular order, but they appear in an order because that's how they're laid out. So one of the things we might think about is, does this child have a co-occurring psychiatric disorder that is leading to or exacerbating or expressing as these challenging behaviors, right? So I have an anxiety disorder, and it's so intense that every time you try to get me to walk into a classroom, I get flooded and I'm minimally verbal and I can't really explain that. So I hit people, okay? Just giving you a very quick, I have no idea if that's the case for X kid, but that's I'm just giving you a very quick example. And or a behavior analyst would say, well, what's the function of that behavior? What is the child getting from it? What's reinforcing it? What precedes it? What follows it? And what skill deficits are driving that behavior? So that's another way to think about behavior. There are things we can think about, I already alluded to, functional communication challenges, side effects of medications and other things, because every intervention has side effects, not just medications. And then there's many other things to think about. What's going on in the family? Is there a new baby in the house? Child's reacting to that. Sensory issues, mismatch in demands versus ability in the environment, asking too much or too little. Medical problems, sleep, bullying, all these different things to think about, right? Okay. So the point is, you have to take a broad approach and think about what might be driving this behavior from multiple perspectives, and not just say, well, it's behavior. Yes, it's a behavior. It's a symptom of what, though, is the question. So if you're in this field, you find this enjoyable and intellectually stimulating. If you're not in the field, you may find it overwhelming and difficult, or either way. But I think if you practice in it, you get used to this kind of approach. So what, as usual, diagnosis leads to treatment. Diagnosis of what's underlying or leading to this symptom leads to treatment. So if we diagnose, that this is primarily a behavioral problem controlled by the environmental responses to the behavior, and a communication deficit, then we might use applied behavior analysis and communication strategies to approach that. So I won't go through all the examples, but basically what you think drives it, the diagnosis, leads to the treatment. So these are common treatment approaches for these challenging behaviors. So ABA, communication strategies, social skills or social cognitive strategies, treating co-occurring psychiatric disorders if they exist and are impairing, psychotherapy approaches, CBT, emotion regulation for kids who are able to engage in that, sensory regulation strategies, treating medical problems if that is present, of course, and then family treatment, including there's evidence-based approaches to help families learn how to think about and manage challenging behaviors, such as one very well-known one, evidence-based, is called the Ruby curriculum. So going a little deeper on some of these etiologies, so only slightly deeper, but co-occurring psychiatric disorders. So there's a fair number of studies trying to look at prevalence in autism. I like this study for a number of reasons, but basically the takeaway from this slide is anxiety disorders, highly prevalent. Lots of arguments about, exact percentages, but highly prevalent. ADHD, quite common, 30%, and then followed by mood, depressive disorders, and then followed by less common things, but they do occur, such as bipolar disorder, psychotic disorders, et cetera. In this sample, 109 kids, no one had a psychotic disorder, but it absolutely occurs. Catatonia also, but not on this list. So the takeaway is it's actually the same as the rest of child psychiatry. Most common disorder, anxiety disorders. Second most common, ADHD, followed by mood, followed by less common things. I spoke a little bit about this already. So then there's the ABA approach to behavior, which is functional assessment. How you make sense of this challenging behavior? And the big question, I'm going to cover an entire field here in 20 seconds, and not very well. But what is the function of the behavior? I.e., what is the child getting out of engaging in the behavior? What's reinforcing or maintaining that behavior? And part of that is what is the outcome of the behavior? And so, quick takeaway, there are really 4 primary functions of challenging behavior. It's really either to gain attention, social attention, which is actually incredibly powerful and we tend to underestimate. Even saying no to a kid is social attention, right? Access to preferred, meaning I get something I want, whether that's whatever it is. Escape or avoidance of something that's non-preferred, math, homework, whatever it is. Or there's the sort of confusing category of automatic reinforcement, which I think is best understood as self-stimulatory, that there's something internal driving it that's automatically reinforcing. So that does not do the field justice on one slide, but wanted to give you a sense. And then medical issues, I wanted to highlight an important area to be thinking about, particularly in our kids who are less communicative or are not really communicating in a way that you can understand as a provider. Could there be a medical issue driving this presentation? So, common medical problems in autism: seizures, GI problems, it really should be GI first, because that's actually the most prevalent by far. The good news is, so the bad news is lots of GI challenges. The good news, though, is tend to be common GI problems, not esoteric GI problems. So constipation, followed by acid reflux, and then other things. Dental problems, always a concern. Sleep is a huge issue, and some other sort of things that are common for all kids. Okay, so I was trying to set the stage for, like, challenging behaviors, end up in the emergency room, need intensive treatment sometimes, and ideally, so then the question is, and then I talked about what might be driving that and what you might want to start thinking about. Okay, great. So who's going to do that? Who's going to assess this and treat and help this family and child? And the question is, you need a lot to do that. The answer is you need a lot to do that, although even having pieces would be good. So over 15 years, I'll give you the example of when I was in Maine, in the United States, working at Maine Health, which is like a large health system there. We built a system of care for these kids. So we built a system to care for not to treat the autism per se, or treat intellectual disability or Down syndrome, but to treat the emotional and behavioral challenges that these kids have. So a mental health care system for kids. And so we built that over 15 years. It had two major components. So an outpatient center called the Glickman-Lauder Center, and a hospital-based program. They're actually just 100 yards apart. And so I'll tell you a little more about that. So this is a very busy slide, but let me walk you through it a little bit. So this is the system of care. So the Glickman Center is outpatient, and so that's the green. And so what's in that center? So first of all, there's a large multidisciplinary outpatient clinic, okay? Who's in that clinic? So all under one roof: child psychiatry, developmental behavioral pediatrics, behavior analysis, speech, OT, I didn't list other things, case management, which is social work, and I'm forgetting some other disciplines. And so that's a team, a whole clinic, maybe 20-something providers, and they're all there to treat the emotional behavioral challenges on an outpatient basis of this population. Okay. So that was one piece. Then another piece, a special purpose school. So, which is what it's called there, but it's basically a day treatment. It's actually not it's somewhat dissimilar, but sort of somewhat parallel to the program I saw yesterday at, oh my gosh, it slipped my mind, the Glen Rose, thank you, Center, where they have a day center program. And it's not dissimilar from that in that it's a school program, but it's a school/behavioral health treatment program. So it's school, but it's also intensive behavioral health treatment. And so we did that both for K-12 and for preschool. And the kids get sent into that from their local school districts, special school. They stay as long as they need to, ideally 6 months, maybe a school year, get assessed, stabilized, and then try to get them back to their local school system, again, to treat the emotional and behavioral challenges and meet their educational needs. And then we did also an in-home program, so early intervention, very young children with autism. So that's the outpatient program. And then across both of these settings or both of these buildings, embedded clinical research. So every program has, a research component, doing research studies. It's just embedded in and part of the clinical program. So it's not like there's a clinical program, someone's like, hey, can I do research? Like, this is a clinical research program. Huge, small difference in words, huge difference in culture and approach and opportunity, which we could talk a lot about. But Anyway, so something I would encourage. And then we have our hospital-based program. So a partial hospitalization program, which is a terrible name, but it's essentially day treatment. It's really not hospitalization. You come 6 hours a day, 5 days a week, and do more intensive treatment than you can do in kind of an outpatient clinic. So you can think of it as a day program, but it's not your school placement. So this is like 2-3 weeks you come in and do this. And then finally, and what I'll talk about more now, is the developmental disorders inpatient unit. So this is specialty psychiatric unit, hospital unit, just for kids who have developmental disabilities, who are having crises of emotional behavioral needs. So this is where they would come from the emergency room or be stepped up from one of these other levels of care. So that was a lot, but hopefully just trying to give you a sense of this, what I call a continuum of care, all in one organization, basically under one roof, one electronic medical record, and different teams, but all part of one program. They all communicate with each other. Okay, so let's talk more about this specialized hospital unit. And I have two purposes for you to learn about this, but also as just a model of this type of care, because you can do this model at any of these levels of care. So specialized hospital unit, it's an opportunity for intensive treatment and assessment, and really setting kids up to be successful afterwards. This kind of hospital unit, and the next slide we'll talk about this, is different than a typical child and adolescent psychiatric hospital unit. So first of all, this is ABA based. We're defining target behaviors. We're taking data 24 hours a day. There's individualized behavioral plans. So ABA based, targeted psychopharmacology, working on transferring skills to parents, schools, grandma, and whoever else is willing to come in and learn, and as we learn from them, and kind of girded in the belief that if we are rigorous about diagnosis and treatment, as I was introducing to you about what's driving what's going on, we can be more targeted, we can reduce polypharmacy, and hopefully get better outcomes. I say that because typically kids in the United States coming into these units are typically on 4, 5, 6, 8 medications, psychiatric medications, none of which is working, right? And I'm not actually, casting blame, because I also work in outpatient and it's hard in outpatient. So I'm not casting blame, but I'm just giving you a picture of what this kid looks like coming in. This is usually not their first stop. This is sort of their last stop sometimes. But why do this? Well, cohorting these children into a specialized unit allows you to apply a different model of care and have clinicians and staff who have some specialty or at least experience over time with the population. That's really different than if you have a typical inpatient unit and there's 12 beds and yeah, there's one kid there who has, autism or intellectual disability. That's fine, but that's usually a huge challenge, right, for that unit to manage that one kid, because it wasn't built for that. So what do I mean by it wasn't built for that? So let's just think about hospital psychiatry units for a minute. So on the left, hospital psychiatry units were originally designed for verbal adults, then kids, still I would say verbal kids, neurotypical kids usually. And so coming from that history, what's the common pieces of an inpatient psych hospital unit? Well, they were developed originally for internalizing problems. The kid who was blue, depressed, maybe suicidal, but internalizing problems. The units rely on verbal interventions. What do you do on an inpatient unit? You have groups, you talk with staff, you process, you develop strategies, all verbally. There's group programming, which by definition, I would say has high social demands. There's frequent, there's staff shift models, of course, usually 3 shifts a day. So lots of staff moving through, because these are 24/7 settings. and shifting schedules. One staff's there for 2 days, they're not there for 5 days, so lots of shifts. And then reinforcement. So how do you encourage positive pro-social behavior in these inpatient units? It's very typical to have kind of general, what I would call general reinforcement systems. System, if you do well, you get 1 point, and that allows you to have certain privileges, and that's good. That's good, and that works a lot for a more typical child adolescent population. Okay, so then we have kids with autism or ID, kids with neurodevelopmental disabilities. So they primarily have externalizing symptoms. So right away, totally different presentation, although I will say, of course, that we do also get typically developing kids who have externalizing presentations, particularly more lately. But most of the kids with the neurodevelopmental have externalizing behaviors. So we need to focus on that and build a system around that. They may struggle with all this verbal. If you put them in a highly verbal milieu, they might struggle with that. They might not be able to participate in groups, or at least not the kind of groups you would see typically run. They, by definition, have been removed from their routines, their caregivers, everything they're used to and typically dependent on is gone because now they're in this hospital unit. Maybe a more subtle but important point is for reinforcement, they are used to a much higher frequency in general and much more specific reinforcement than what is available in a typical hospital unit. Like they're used to I do a good job, whatever, I get to watch my favorite, video for 20 seconds and maybe play it 6 times over. And that's my reward for reinforcement. Could care less about I don't understand and could care less about this point system, and I get to go to the cafeteria like that. I don't care about that. So that's not reinforcing for me. So that's a big challenge. And so what ends up happening because of all these things, when you get that one kid or a couple kids and you stick them in a typical unit, often what happens is they get agitated because this isn't working for them. Staff sometimes get agitated too. They're excluded. They're not being reinforced. They end up in their room. They're told to stay in their room. That doesn't work for them. And so they get agitated, aggressive, restrained, et cetera. That's what typically happens. Not always, but that big risk of that happening. So, that's the kind of issue. That's why, I'm suggesting a different model. So what is this different model? So specialized units typically have a pretty wide multidisciplinary team. This is an example of one. And so you'll notice a couple things here that's different than typical child psychiatry units. Typical child psychiatry units, hospital units do not have behavior analysts. They often don't have psychologists, and certainly not psychologists who are behaviorally oriented. They typically don't have speech language pathologists or occupational therapists. So this is a much broader team than most inpatient units have. And so I want to give you an example of a child to kind of bring this to life a little bit. So typical admission. So 6-year-old girl, autism, mild intellectual disability, let's say IQ 58, let's just make it up. Why in the hospital? Well, because this young girl has frequent tantrums totaling up to 2 hours a day. And those tantrums are accompanied by physical aggression toward other people, and say 20 to 40 aggressive acts a day during these tantrums. So that's the problem, okay? That's the symptom. That's why I ended up in the emergency room, got hospitalized. Communication, minimally or nonverbal, and supposedly has a communication system that she uses at school, doesn't use it at home or anywhere else. Pre-K educational level, physiologically is awakening 3 to 4 times a night for significant periods of time. And coming in is on 4 milligrams a day of risperidone, which for those of you who aren't in that area, that is a very large dose. That's an adult dose for the population. She's 6 years old, and she's getting PRN Benadryl, and none of that's working, right? Or else she wouldn't be with us. So this is just a very quick sort of I'm giving you the salient points from, you do your initial history examination, talk to lots of people, talk to the parents. This is like sort of the distillation of that. So we do that, we take the history, we start observing, and what do we see? So we see, first of all, that this girl is tired and sedated. So she's tired because she's sleeping, very broken sleep, waking up 3 to 4 times a night. And she's sedated because she's on 4 milligrams of risperidone, which is enough to knock a 6-year-old over. And would definitely knock me over if I suddenly took it. So she's tired and sedated. She also has a lot of communication frustration or inefficiency, is what a speech language pathologist would say, because she really doesn't. This happens often. She uses PECS, she uses a communication system, but she's not able to spontaneously, independently use it. So it's not really super functional. She was also confused, disoriented. She didn't have kind of typical supports that you want to see for kids with her level of challenge, like visual schedules, other things. This is actually kind of facetious, but she also generated a lot of inconsistent expectations because she was super cute. And that's great for her, but she was like getting away with stuff. She's like hitting people and getting away with it, in the community, but even with our staff, our highly trained staff, because she was kind of super cute. So, being super cute is great, but it wasn't really helping behaviorally. And so functional behavior assessment as part of this initial assessment showed reinforcement of the behavior by people attending to the screaming. So that's an attention function. And people were letting her escape, whatever the situation was. So that's an escape or avoidance function. So those were the primary functions of this behavior: tantrum with aggression, escape, and attention. And I presented to you, that functional behaviors, I said there's 4 functions, as if the world is simple and you just have one function. But in reality, behaviors typically have multiple functions, which makes it more challenging. So what did we do in this hospital unit? Again, the problem is tantrums plus minus aggression, usually plus. So what did we do? So, because there's many things we could do, but you want to do as few as possible, you're going to have the highest impact, right? So what we did is we worked on her communication. She did not have a functional communication system. So our speech language pathologist, reinforced by our staff, who are all trained in picture communication systems, worked on that and increased her ability to use that system, and emphasized with parents, because this is a common thing, even though you know what she wants, that doesn't help her communicate what she needs. And I'm not being parent blaming, like parents know their kids and they often say, I know what she wants, and that's great, but that's not good enough. That because then the child's not with you. It's totally different for them to be independently, spontaneously communicative. So anyway, worked on communication, worked on the behavioral response, of course. And it's behavioral response, so we got to change us. We're changing her, but we're changing her by changing us, right? So she had an individual behavior plan. We reinforced her with reinforcers she actually found reinforcing when she was not having tantrums, gave her a social attention when she's not having tantrums. And then when she did do that to try to escape something, we didn't let her escape. So in other words, she'd have the tantrum, then we represent whatever the demand was. And took her off the risperidone because that wasn't working. Also got rid of the Benadryl because that never works. So then she had a major sleep problem, sleep deficit, which is common in the population. So first we did what we do with all kids, which is good sleep hygiene. And that actually that takes care of a lot of it. However, she had a true kind of physiologic primary insomnia of whatever etiology, we don't know. And so we did end up, even with sleep hygiene, giving her a medication to help her sleep, which was called trazodone, but we still did sleep hygiene training with the parents. And then finally, we did all of the things that I would call kind of good autism practice, which is structuring her environment. So giving her a visual schedule, giving her countdowns for tasks, giving her breaks, all of these things that are like good, basically good practice. So what happened? So as I said, we take data every 15 minutes. So, and we were taking on a number of target behaviors. So this is her aggression graph. So this is her hospital stay. This is a real kid. This is real data. So 42-day hospital stay, which is long for the US, but that's what tends to be in these units. And this is what you see. So she came in with aggression, 40 to 70 aggressive acts a day. There's a similar graph for emotion dysregulation or tantrums that I'm not going to show you. And this is what happened over the course of time. So there's a whole bunch of things there's like a ton of information in this simple graph, but I'll just point out a couple things. So, got hugely better over time, right? 95% reduction, fantastic. Can I tell you which of the multiple interventions we did caused this? No, it's not a controlled study, but this is real world treatment. So it's a mix of things. Does it get better right away? No. Does it get better in 10 days? Almost never. Usually takes weeks. We're trying to change behaviors that have been developing for years. That's not going to happen in 3 days or a week. Almost never. Okay. Nor is a medication typically going to do it, except for the somewhat uncommon presentations where it's really extreme psychiatric disorder, and we diagnose, we treat, and the behavior was tied to that. But otherwise, it takes multiple things. This child didn't get a bunch of medication from us except for the trazodone for sleep, but others do. The other thing to note is behavior changes over time and as a trend, right? So we're really good in hospital psychiatric units at reacting to what happened this morning or last night or the day before. Oh, she had a restraint. So, okay, the medication isn't working. So we got to change this or change that. That is a bad idea. If we reacted to each up and down here, we would go nowhere, right? So it's really hard, but you have to be a attentive, thoughtful, but non-reactive treater. So, because what happened yesterday is almost meaningless. It's what happens over days so I don't believe, even when we start to see something going down, I usually say at least a week before I believe anything, right? So that's just another piece of this. So I'm talking too much, and we're starting to run out of time. So I'm going to accelerate a little bit because I get very excited about the clinical piece. Okay, so we'll tell you a little bit about these specialized units. We did a survey in 2011. We only found 9 of them in the United States, 9 units in the whole country. There are hundreds of child and adolescent units. There are hundreds and thousands of adult units, but we only found 9 of these, of which we ran 1. Average length of stay across those units, 42 days. I didn't pick that example. That girl also stayed 42 days. That's just a coincidence. 2/3 of the patients with autism, 1/3 other developmental disabilities, Down syndrome, ID for unknown reason, et cetera, Fragile X, whatever it is. This is a study we did. So that was one study. Here's a different study where actually this is a single site study. So we looked at our own site and we wanted to see our kids getting better. And we had a theory that we did better with kids with autism than we did with non-autism intellectual disability. And so that's why there's 2 lines here. The short of it is they both stand with our perception about ourselves as a treatment team. And this is a busy slide, but I'll just say, so this is looking at a measure of aggression, self-injury, and tantrums. So that's a good measure for us, right? Because that's why they come in. At admission, discharge, and then 2 months after discharge, we called up the same caregiver who filled it out and had them rated again. And this is what we found. So this is the aberrant behavior checklist. I don't, expect you to be familiar with this measure, but I'll tell you that 7-point change on this measure is considered highly clinically significant. That's what clinical trials are usually set at. So we're getting a, 15-point drop on it, so highly significant, and then really nice to see some pretty good maintenance at 2 months. So this is just calling them up at 2 months, whatever's going on after the hospitalization, whatever they're getting or not getting, still maintaining pretty good gains. So we were pleased to see that. So then we did the same thing. So we formed a research network, as was alluded to before, these 6 sites, including Brown University, Bradley Hospital, where Dr. DeLuca and I trained. And we come back to this in a second. Across. So same measure, admission, discharge, 2-month follow-up. And we basically saw the same pattern. You know, kids coming in high, as you might imagine, they drop down, although some variability across these units, how much they drop, and then pretty good maintenance at 2-month follow-up. Of course, we want to know, why does this unit not do as well as this unit? I will say that blue line is quite familiar to me, that site. But anyway, unfortunately, the answer is we didn't, I think we do a good enough job setting up the study that I could really tell you what is producing this variability, except there was a trend toward these 3 units at the top that got they got improvement, but less improvement, had shorter length of stay on average than the 3 units here that got greater improvement. So there was some trend to that. So in other words, if the stay was too short, perhaps the effect wasn't as great. But that's what I could tell you about that. And then briefly, we used this network to then run a very large study over many years called the Autism Inpatient Collection, where ultimately we enrolled over 1,500 kids and their parents. And the purpose of this was twofold. So the first was, the smaller purpose was so that we could study these things, including the figure I just showed you, and learn as much as we could about these kids and these units. That was the first thing. And so we've published a bunch of papers on that, and that's great. But the second purpose is more important, which is to produce a large data set that is available to all external investigators, including you guys, about this population. Now, why does that matter? Well, mainly because this population is really hard to study. They do not show up to outpatient treatment studies. They do not show up. You're not going to be able to recruit them. They're under too much stress. They're too impaired, or they can't do the protocols, that are in their study. So this is a heavily under-researched group. And one way to frame this group, so 50% are minimally verbal, 42% have intellectual disability by a very generous measure of intellectual ability. And so our goal was to make access to this group available to other researchers. And so I'm happy to say that as of 3 days ago, after 9 years of work, this data set is now available. And I'll skip to that. Right here, it is available through the Simons Foundation. It's called Safari Base is their website. And so this whole data set, which is quite rich and extensive of phenotypic measures and genotyping, is available to approved investigators. Approved meaning you have to apply and say, this is my research idea, and I'm from the University of Alberta, and I'm not a weirdo, and they'll give you access. Or maybe even if you are a weirdo, but they'll give you access. So this is very exciting, something we worked toward for a long time. So I've run basically out of time. So I'll just tell you that the last couple things I'll tell you is we repeated this study that we did in 2011. We just repeated it last year, because that's what you do when you get older. You just repeat your prior successes. No, I'm just kidding. But so there were 9 units before in the US. There are now 20 that we could find in the US. So there's been a doubling of these specialized units. Certainly not enough, but that's kind of remarkable that in a decade they've doubled, because these are not easy units to start or run or pay for. And then there's lots of detail here we can't do. Behavioral challenges. The most important thing I'd like people to take away clinically is it's a multifactorial etiology. So you need a multidisciplinary team to treat it. Usually, it's certainly by the time kids get to this level, right? So one behavior analyst or one child psychiatrist, no matter how wonderful they are, is not going to do it and figure it out when they get to this level. That was a joke about me, but anyway. And so it needs a multidisciplinary approach and looking at really key factors. And I listed some of the key factors there. A few resources. We have a publication on kind of best practices for psychiatric hospital care from JCAP on the right. There's a parent medication guide we were part of on the left that talks about a lot of these things. And these are both available for free download. Told you about Safari Base. These are my collaborators, co-investigators, funders, and thank you very much.
Thanks so much, Matt, for the great talk. Really,
You have to turn on.
really interesting data and a really important part of the population that we serve that doesn't get talked about as often. So thank you for that. So now we have the chance to open this up for questions. Before I do that, I also wanted to thank Megan and Ariane for all of your help in making this happen. So I will be taking any questions from the audience, and then Dr. Leon will be taking any questions from the chat. So maybe we can start live if you want to ask a question here. Yes.
Hi, very great talk. So we always hear this thing in the media that the autism cases are increasing year by year. Do you have any idea of like, is it because of better diagnosis that's happening, or
we have a little bit of an echo, so we can't hear you super well.
Okay.
Can you kind of yell it out?
Yes.
And I can repeat it here.
Autism cases are increasing from last couple of years. Do you have any indication of what is that? Is it because of more like better diagnosis? That's why.
Okay.
So just to recap, the question was about the increasing incidence of autism and the reasons behind that.
Okay. Thank you for asking me one of the most difficult questions there is that has nothing to do with my talk, but here comes an answer. Thanks a lot. We'll talk later. So the question was, increasing prevalence. How do we understand this? Think about it. So seems like a very simple, basic question, which it is, and the answer is very complicated and not fully understood. So here are some pieces. So first of all, there is no doubt, there is no debate, no doubt in my mind that the expansion of the diagnostic criteria is responsible for a huge portion of the prevalence increase, right? Many, many people who are diagnosed with autism now would never have been diagnosed in 1980 or 1988 when I got into this, or even 1995 or 2000, right? So that is an undeniable part of this, and that's really important, and people kind of skip over that now these days. I want to talk about environmental toxins or whatever. That is the bulk of it, and there's studies that illustrate that well, besides it just making sense, it illustrates it well that also many people who used to be called intellectual disability, or actually were called mental retardation in the past, now are recognized as having autism. They may or may not also have a disability, but now they're recognized as having autism. So that's another diagnostic shift. Then we get into lots of other things. That's the big one. But then we get into awareness, screening, which are good things, right? Like more awareness, more screening, more diagnosis. Then we get into more challenging things. Self-diagnosis, very liberal diagnosis, because in the United States, at least, I don't know about here, but it is the ticket to services. So sometimes someone might get diagnosed that may or may not meet some rigorous criteria, but it's a child who has challenges and needs services. So there's some of that. And then there are some unknowns, that we don't know about. And supposedly we're going to have the answer by September, according to the Secretary of Health and Human Services of the United States, which I can assure you we will not have. But although it is a lot, I shouldn't say this when I say it's much easier to run a research study and have an answer in 3 months or 6 months if you already know the answer before you start the study. That's a really efficient way to do research.
Thank you. So we now have a question online, which will alternate questions from Dr. Daniel Lee, our actually clinical department head, who says, thanks for your insight and experience. Can you speak to the transition of youth to adults? Do you know of similar success in the adult ASD population in specialized units using this model of care? Comment that these lengths of stays are pretty amazing from what you described and relatively short compared to some of our rehab units in the adult world where lengths of stays are quite long.
Okay, great. Thank you. Great question. So about adults, what is there a parallel for adults? So in this area, I believe that Canada is actually ahead of the United States in this area, in that I've been aware, and there's been publications for quite a while, although I've never gotten to visit one, that there is a network of adult intellectual disability units in Canada, which I think kind of grew from a history of them, and currently also in the UK, that does this type of work, but I don't know much about them and how they do the work. But I've seen several publications. There's a researcher with last name Lunsky from Canada who's published on this. So there are some adult units, although I can't tell you if they're like really follow this model or not. In the United States, it's the opposite situation. There are almost no units for adults. There's like 3 in the entire United States, and they're very hard to get it for adults. They're very hard to get into. There's one in Pittsburgh. There's one in Baltimore, and I know that because people are constantly asking me. So we have big trouble in serving adults who have these challenges, who have developmental disabilities, and there are adults who have this. People used to say, oh, well, this is really a youth problem, and they grow out of it as they become adults. There is some of that. I think for many of us, there's some mellowing as we get older sometimes, but there are people who certainly it does not change, and I have plenty of adult patients myself, who are 25, 30, 35, who started with me when they were 15, so and who still need still have challenging behaviors, need a lot of care. So a lot of needs for adults, which I'm sure does not surprise anyone who's encountered this field.
Thank you. We have a question in the audience.
Thank you very much. I'm in development. I'm legal marketer on which is quite outpatient and flexible. So I'm curious, in your model, how do psychiatrists interact? How do those roles shake out?
That's a great.
Sorry, Matt, just to repeat the question, we wanted to hear about how the psychiatry and the developmental pediatrics world interact regarding these clinical services.
Yeah, thank you. That's a great question. So I'll tell you how we were doing it in Maine. But I guess first I'll just say that everyone is kind of doing it differently, and including there's not a small number of places where the two are not working together, which is not great, which happens for lots of reasons, particularly in academic medical centers. But what we did is we did bring them together, and the answer to your question is the developmental pediatricians tended to, we had them, or they desired to focus on more initial diagnosis, support of very young children, the kid kind of program is our psychiatrists more focused on the school age population, 18, because that is where the co-occurring psychiatric disorders and challenging behaviors predominantly emerge. And so some of the kids would continue to be followed by developmental behavioral pediatrics, but a lot not. They would sort of get handed off to child psychiatry. Whereas we didn't have a lot, we didn't do a lot with the under 5s because fortunately they didn't fortunately, they wouldn't be on medication typically, and they would not need kind of our approach. So that's how we work together. Yeah, I think that's what I would say. Yeah.
So this is more just a, I guess, a resource query from online. Can you repeat, please, what we can download? I think maybe a couple of the slides are a bit quick, so maybe this person would just appreciate going back to
So yes,
resources.
thank you. So the download question, I think, was about this database that we've made available through the Simons Foundation. So this is, it's base.safari.org. So if you are interested in this population, or you're not interested yet, but you're a young or early career researcher and you don't have money to collect your own data, well, here's a whole data set you can use and publish on, right? So go wild. I mean, read the papers we already did, but then do your own. And cite them, of course. So that was the download. And then I think there was one more, which was, yes. So this parent medication guide, and why did I put up a medication guide? Because as you can tell, that's not actually my focus, is not medication. But the reason I like this guide, and I'm biased because I was one of the authors, but is that we spent half of it talking about all the stuff before medication. So, or in addition to medication, you know, communication systems, behavior analysis, et cetera. So it kind of walks through some of what I presented in some of those early slides. So that's available at acap.org. And then this is an article on best practices, which I think is freely available from JCAP. Yes.
In your graph that you showed about different centers, the biggest centers that show the biggest improvements also show, or the other way around, the ones that show the least improvement at the beginning show the flattest line afterwards. Is this something that is obvious, or is this is there a reason behind it that maybe a bit more?
So the question was about comparing the different inpatient units and the decrease in symptoms and the progression over time, and why the different patterns may occur, especially on those that show the least decreases, so the least improvement.
Yes, and can you, but I didn't hear one part that I think was the key, which was, you said that there was one particular part you were curious about. Can you say that again?
When the kids are in center, there's improvement.
Yep.
But for those that are big improvement, there's the most bounce back.
Yes.
And for the ones that are least improvement,
yes. Okay. Great observation. So he said, you know, for the ones who have the greatest improvement, they also have the greatest regression or bounce back. Although, again, still are coming back to a level that is almost non-clinical on that scale. So I don't know whether, I don't know, but I think that probably it's the more obvious that just the more you improve on something, the more room you have to kind of regress to not a mean, but backwards. You know, the improvement is so dramatic, maybe it wasn't. So I'll just say that blue line, the one that had the most improvement, but then the most regression back, that was our unit, and I just happen to know. And I think that we did so much that some of it was not maintainable at home, and so it's almost like we did too much in a way. Like we would, from a sort of public health standpoint, or whatever, would have been better if we had done a little less, and they didn't improve quite as much, but then didn't regress as much either. Does that make sense? Okay. But that's a really good observation.
I think we're running out of time here, so I don't know if we can maybe just one last question. I have a child who, and this is anonymous, I have a child who has both a mild intellectual disability and severe ADHD. Do children like her need mental health care in a hospital, therapeutic care, or both? And I think there's some difficulties accessing resources for the child with these neurodevelopmental disabilities? And also a question, do children with these diagnoses, are they considered to have a mental illness?
Okay, that's a great question. So child with I think intellectual disability and severe ADHD, and what kind of treatment do they need, and do they have mental illness? So I think the way we think about it for this child, as I'm understanding it, is they have intellectual disability and they have severe ADHD. And if that, let's just assume that's been well diagnosed, then we would call that a co-occurring psychiatric disorder. And the real question is, or what matters is it impairing for the child? So there's their intellectual disability and everything that comes with that. And then if they have severe ADHD, and let's say they're severely hyperactive or severely inattentive or both, I would imagine, since the word severe was used, that that's impairing, right? They're having trouble attending to things, learning, getting up in the classroom, running all over the place frequently, so I would call that impairing. And so then if they have this separate disorder that's impairing, then yes, technically you would say that's mental illness, but ADHD is so common, I think we would just say, yeah, they have a co-occurring psychiatric disorder. Think if it's impairing, merits treatment. And in the case of ADHD, we're lucky. We have very good treatments for ADHD. We have multiple treatments, environmental ones and psychological ones, and some of which have actually been tested in neurodevelopmental populations. So that, I think that's the answer. But the thing I want you to take away is it's less important about mental illness, et cetera. It's what is going on with this child that is impairing them or slowing them down on their developmental trajectory, on their functioning. And if one of those things is diagnosable ADHD, and we can either restructure the classroom, give them a bouncy seat, do those kind of interventions, or we can give them one of the several approved medications for ADHD, one medication, several different kinds, and help them focus and learn, and then and ameliorate that improvement. That's going to be potentially hugely beneficial. So I actually love when I get a kid like this, because we can actually help a great deal, usually.
Thank you so much, Matt. So this brings us to a close. We have some materials and some newsletters if you want to keep up to date on what's happening and our series of speakers, and they are in the back. Please also sign up if you haven't done so before you leave. And
slides are your
Yeah.
And Dr. Siegel is happy sharing those slides so we can connect around that. So thanks everyone for coming, both in person and online. And we'll send off Dr. Siegel with a 1-minute send off.
Thank you.